We're going to introduce Dr. Szurman. If we could have first, Peter, can you hear us?
Yes. Welcome to Sulzbach and good morning to Frankfurt.
Good morning. And can you introduce, are you doing the macular hole or retinal detachment? We understand, I'm not quite sure which case you're doing. I think there was a change. Is that correct?
Yes, we have a fresh PVR re-detachment of a quite young patient, 48 years old. He had 3 surgeries for retinal detachment in a secondary center. And yesterday evening he was referred to us because he already developed PVR and he has a redetachment under the withdrawing gas bubble.
And what will be your approach here? He previously had scleral buckling surgery, is that correct?
No, she had 3 times vitrectomy with gas. The first time combined with cryo, the second time combined with phaco, and the third time combined with epiretinal peeling, obviously ILM peeling. And now he has an inferior and nasal redetachment under the gas bubble. He has beginning PVR membranes in the inferior hemisphere, and he has some vitreous remnants in the periphery. That's what I've seen yesterday.
Okay, so another easy case for you. Very, very good. We will come back shortly. Let's, if we can switch back to Marco Mura for a second, same room, but I think yes. So Marco, tell us where you are now.
I'm making an opening here in the cornea. I get here one of the forceps. Let's see, Stan is proposing. Can try maybe with this one. That's it.
And we saw, Marco, that just before this, you'd removed the epithelium to improve your view as well. Is that right?
Yes, it's a little bit better now.
Oh, yes, that's a lovely view now.
What forcep is this?
Can I have the pressor, please? I don't know.
Is this the David Steele? This the David Steele forceps?
It looks very Italian, if you ask me.
Yeah, it looks good, but it doesn't work.
Oh, wow, that's it.
Yeah. Whoa.
Works. Like Ferrari, they look good, but, you know, invertimi.
It looks more metallic, Marco, yeah, it's not.
Yeah, it's a piece of metal.
Eccolo qua. It's, I don't know, it looks like a metal, yes. Look at
and you didn't, and this was not told to you that this was inside the eye, correct? This was a surprise.
No, it was a surprise.
Nice surprise.
Okay, thank you very much.
Oh, that
foreign body.
Nylon. Thank you,
that
Stano.
wouldn't have been doing any good, I guess.
There's no castro.
It make it more excited.
The only thing your eye doesn't have is a tumor, and we can send you one from the other operating room here. So,
yes, I think so, because he has everything. Macular roll, which is like a PVR break, actually. You see it with roll edges. I don't know what I'm going to do with that thing. Put some amniotic membrane.
You could do that, yeah. You could. Amniotic membrane might be a good idea. But yeah, and you've got plenty of it apparently. So
Stano was telling me next time he gives me a
But I have a serious question, and that is, had you not had so many posterior and large breaks, would you have put a macular stabilizing bubble of perfluorochemical in the eye somewhat earlier? If you did not have
I never do it very early, but yes, if I'm sure the posterior pole would have been flat, would have been without membranes and no those large breaks, yes, I would have done it. Now it's not possible. I will have probably to flatten it under air or under silicone oil directly because...
Yeah, it would go subretinal immediately.
With those large breaks, it would go subretinal immediately, so it would not work. Do you have a bone forceps? What is this?
But we were joking about the amniotic membrane for these large breaks. I think this case is really extreme and it is not possible to cover with amniotic membrane all the breaks. but I have to say that it works very well. It works very good to prevent scarring tissue, that fibrotic and calcific tissue around the choroidal breaks. And so from time to time I use it for amniotic membrane.
Seems to have some anti-proliferative action.
Anti-proliferative action, yeah. It covers and it prevents this scar.
We can replace the whole retina with amniotic membrane, I think.
Yeah. But
We'll watch that with interest.
this is, you need, I guess you need a very special amniotic membrane for this eye.
I'm impressed by your corneal suturing. I am not allowed to suture the cornea. My wife is a corneal surgeon, and she says I'm a terrible corneal suture, so you're doing it beautifully here. So, very.
Never argue with wives. That's the first rule.
Yeah. Familial harmony. Let's rejoin Rahmen in Paris. Rahmen introduced blue stain after your vitrectomy.
Exactly. So I put the blue stain. So depending on how the fundus is, you can wait 0 to 2 minutes. There has been no report of toxicity even in animals up to 2 minutes. So in myopic eyes, when you want a good contrast, so we can wait up to 2 minutes. So I'm going to wait 2 minutes.
Good.
By the way, we have here the retinal attachment still. As you said, this is the other disease of this patient. So during waiting, I just cut the flap, just decrease the traction. And as you can see here, with low aspiration, we have a very good stability of the retina, which is really good. Then once I have aspirated the blue, I will switch to a flat lens to have a better view of the membrane and do the dissection. So I'm just waiting.
We will come back at that
20
moment.
more seconds.
We will come back. Could we go to Peter Szurman, please, in Sulzbach? So, Peter, we're back with you.
Yes. So this is a situation. Obviously, the first surgeries were focused on the superior quadrant and to the nasal quadrant. And now we have this nasal detachment coming from this laser area. And he has PVR membranes in the inferior part. And the strategy is that we will first stain the PVR membranes. We do it with dual blue. Then we stabilize the center with perfluorocarbon liquid. And then we will shave the vitreous base to see if there are many vitreous remnants.
And is your plan, so let's, I have David Steele with me who loves scleral buckling. Is your plan to add some buckle to this eye? I mean, 3 PVR operations without a buckle is probably somewhat unusual, no? Or do you think, what are you thinking, David?
Well, despite what you think, Don, I don't use many combined scleral buckle vitrectomies. I think scleral buckling on its own is a great operation, but I think combined, I don't often do that, although I know there's a lot of proponents of that technique.
Sure. Mm-hmm.
Peter, is that unusual in your practice? By this stage, will the patient have usually had a buckle, or is that uncommon?
Yeah, of course, the buckles are withdrawing. Of course, we do it, but a buckle for me is rather a technique for primary single break situations in younger patients, but not really to support the vitreous base. There are selected cases, especially if you have a shortening of the retinal periphery, but this doesn't seem to be the case. And these PVR parts are rather centrally, so an encircling band will be too peripheral.
Yes, it looks quite central. It looks quite focal, the PVR, and it'll be interesting to see how it stains.
Yeah, let's come back. Let's go to Essen for a moment here. Yeah. If we can go to Dr. Bakrakis and see he's doing his endoresection.
Mit Dual Blau.
So, Nick, we're with you.
First of all, I would like to say hello to Klaus Eckert and thank him for his invitation. I didn't do that, so sorry
Could,
for
could
that.
you increase the volume from his room, please? It's difficult to hear.
Yeah. So this is a 25G hyper-width cutter, double cutting, and I have raised the intraocular. Before doing the endoresection, I did a biopsy for genetic analysis. After that, raised the intraocular pressure, and I saw that there is a lot of bleeding, so this tumor is very well vascularized. I raised the intraocular pressure to 80. Still there was some bleeding, so I raised it to 90. At the moment we have a 90 intraocular pressure. The systolic blood pressure of the patient is about 100. So now I have a good control of the bleeding of the tumor. My intention is to remove the tumor. It's a mushroom-shaped tumor. Fortunately, there is no infiltration to the ciliary body, so it stops right at the ora serrata where I'm just now.
Sie gucken auf das Bild, ob es
And
überstrahlt ist
the
oder zu
point is
dunkel.
to go down to the sclera.
We need to leave you, and let's go back to Paris. Ramin, we're back with you. We see you have an intraoperative OCT image. If we can
Jetzt
see
macht's
his...
noch keinen Sinn, ne? Nehmen dann Eckart und Kill.
So you're having to push the forceps into the eye a bit, Rahmen. That's very difficult.
Und wechseln. Geh nochmal runter. Wir
So,
müssen-
Don, do you have any techniques when you have these long eyes to improve your reach?
Well, the usual things. I think we soften the eye and press in, and you can soften the eye quite a bit. And then the other thing is you can take the trocar out, remove the cannula completely, and gain another millimeter or two in that way. I rarely use long instruments. I think we have them available, but I agree with Ramin that when you have to push in, it makes it trickier. Of course, we've seen Khalid Al-Sabti, who has his posterior depressor. He puts a platform depressor behind the globe and then pushes the macula up while he peels with the other hand, and he's demonstrated that at other live surgical meetings.
Yeah, quite tricky.
Quite
Looked
tricky.
quite tricky.
Especially with the
But
chandelier,
another-
presumably, with the
yeah.
chandelier illumination, yeah.
But the other,
Is that epiretinal membrane at this stage, Rahmen, or is that ILM you've got? So Rahmen, you've just put a filter in, have you? What have you done there? What have you done with the filter?
So what I am sorry, what was your question?
You've changed the image on the Ingenuity.
Did you change the light filter in the Ingenuity?
On the Artevo, you mean? No, just it was adjusted to do a better image because it was not good enough. Now it's better, I think so.
Oh, you
So
certainly.
just the light and the color was adjusted. So you see that here is the ILM. So the other one was the membrane. So I have the ILM here. So I try to have, so the problem with when you depress is that also you lose the focus, and depending of the angle of the lens also, because this is a contact lens, I have a different focus. So my assistant is trying to have the lens as much as possible flat, but of course when I'm depressing, it's just moving. So here is the ILM. And you see here that we have again some remnant of the vitreous with pigment here at the edge.
I noticed that you didn't use triamcinolone, Rahmen. Is that?
There's some the pigment. Sorry?
You didn't use triamcinolone before the membrane blue, or the brilliant blue G at least.
No, I didn't. So with the blue, I see quite well the vitreous. So when you were not with me, I noticed that on the nasal side there was some vitreous, and I dissected. Because with the blue, especially if you use the wild field, you have a quite good view of what's happening.
We will come back, Ramin. Let's join
in some
Peter.
cases, I use triamcinolone.
We will come back. Let's join Peter. Peter, we see you peeling now.
Yes, so I'm astonished because after 3 vitrectomies, I would have estimated that there is already an ILM peeling done, but it's not the case. So to my personal experience is the central PVR, even if it's not really visible with fundoscopy, this is the main reason for late deterioration of these patients. He still has a vision of something about 2200. He had a macular off situation with the first surgery, as far as he told us, but now it was not macular off, and the peeling is nearly done. Okay, and I will switch now to the inferior periphery to look for PVR membranes. I'm not sure if it's well visible because it's in the periphery and with the central.
Oh, we see very well. We see very well.
Fine. Okay, so this is not to peel. I will address it again after PFCL later. And here are the PVR membranes, but I need the peripheral loop, so we change.
Gracia, so these membranes often don't stain very well. Have you got any tips how to improve staining in these early membranes?
Yeah, very good question. I'm not sure if it's evidence-based, but we had the old rule that dual blue is for ILM peeling in PACA surgery, and normal trypan blue under air, that's what I've learned, is for PVR membranes. But in the last years, my personal experience is that dual blue is staining everything better, even PVR membranes. So I have filled the eye completely with dual blue, and it stains quite good.
So you fill the eye completely with dual blue?
Yes.
It's quite strange. How can you fill it completely? Do you stain under air and then you fill the eye, or do you stain, what I do quite often is if I want to stain peripheral membranes, I stain under PFO or stain under air and start injecting the blue from the periphery. So it will, along the air bubble, go downstairs and stick.
We will come back to this topic. It's important. Let's go to Essen. We see that a lot of progress has been made. So, Nicholas, we're back with you. And you have isolated, you now have a retinal edge, we see.
So I'm doing the choroidectomy here, just at the edge of the tumor, and I simply remove the tumor by trying, like in a phaco procedure, to always be on the tumor, like on the lens, in order to avoid too much flow. Flow is my enemy here in this situation, because if I have too much flow, what I don't like is that the optic disc at the moment is occluded, so also the arteria, so I go down with the intraocular pressure a little bit.
You were at 90. What are you at now?
No, I'm at present I'm at 70. Now I'm at 65. I lowered it in order to have some perfusion. Go down to 60. 55. We go down. So
Nicholas,
now you see there is perfusion. Go down 50.
Nicholas, is this with hypotensive anesthesia or
no, it's not. No, it's not. No, it's not. The pressure of the systolic blood pressure of the patient is about 100.
Okay.
So now I have some perfusion, and you see this is the area where the short ciliary arteries are coming out, and this is always where the bleeding comes from, around the optic disc. So I'm very relatively close to the optic disc, as you can see here. I try to undermine the retina here, and you see how the blood flushes in. It can happen in a second, so I have to be very cautious to have a right balance between bleeding and perfusion of the central retinal artery. But that's what I like to have. I have to have it pulsating here.
The open duty cycle of the hypervit, I guess, must be a big advantage in these cases with the to improve the ability to take the tumor out. Is that something you found with the dual action cutter, as in the hypervit?
I don't care about the duty cycle, to be honest. I just use. Let me see. This is a critical situation here to avoid. No, I don't care about the duty cycle. This was before introducing high cut cutters. So this is a 20,000 cut rate. So I don't think. So as you see, I try to scrape out tumor. Remember that the tumor is irradiated, so.
We'll come back, Nicholas. Let's rejoin room 2, if we can. Yes. So, Marco, tell us where you are with your case.
I think I'm a very good point. I remove here, there was some epithelial downgrowth above this area. I remove it. It was connected to a large area of unremoved vitreous. I remove all of it. I can show you the periphery. Give me the depressor. And it looks like the retina is unfolded. You see now it's in the periphery. Looks like it's better. One membrane more here, I think I have to take out, and this one. And then after I remove these two membranes, I think I'm going to try to flatten it.
Kann man das sehen, oder ist das zu weit außen?
Here has been all removed. Here was the area where the foreign body was located. And as you see now, this is a fibrotic membrane, but there was on the top another layer, basically, which I removed. It was extending here to this area. So
your plan is now air?
it starts looking a little bit more like...
Your plan is to do an air exchange now to flatten the retina?
Now I have to remove still a couple of membranes here on the top because the superior part was the last part I left. You see here, there is some membranes in here. Because if I don't remove this one, I'm not sure it's going to flatten. And after removing this, I will go under air, yes. So maybe
Shaving.
10 minutes I will be under
Okay.
air.
We will come back. Let's rejoin Paris if we can.
Della of 6.
Ramin, we saw you checking the OCT again.
Exactly, I'm checking to be sure that the macula is doing well despite the dissection, and you see that there is no membrane on it, and the fovea, there is no opening, there is nothing here, so it seems satisfactory. So the macula is treated, so I will have to go back to the periphery. So here I found the vitreous, which is very attached, so I dissected until here, you see it. It's dissected at the area of retinal attachment, so until the edge of retinal attachment. So at some point, it's very attached to the retina. I cannot go beyond. Here, for example, there is some vitreous. But when I try to pull it, the vessels are moving, so I don't want to make any new tear, so I will not dissect there.
Yeah.
So I think we are at the limit of what we can dissect for the vitreous too. So I will just shorten this and then mark the tear with on the diathermy, and then make a fluid air exchange to treat now the retinal attachment as you suggested. So that's my next step.
Very good. We will come back. Let's go back to Sulzbach. So, Nicholas, we're with you now.
Sulzbach, yeah. So we are shaving the periphery.
I'm sorry, Peter.
And that's exactly what I've expected, that nasally the vitreous was adherent. It was only detached up to the laser area. You see here is a laser area, and it was detached only until then, and the periphery was full of vitreous, and we've removed most of it now. Weiter, Darren. And this is what I always experience. PVR doesn't happen just by chance. It happens mostly by vitreous remnants, centrally and peripherally. And
we completely agree. It's always the problem, retained incomplete vitrectomy in the periphery with recurrent PVR. Always difficult. But it looks much better already, much better.
Yes, I think it's okay. I haven't found a hole, so a break. And the periphery is there is still fluid, so there is no real break. I guess this is mostly the case. It is a small break at the edge of a laser burn. And maybe you will not identify it, but it doesn't matter because we do a laser 360.
Very good. Let's go to Essen now, to Nicholas. Nicholas, we're back with you.
So, I think I removed the tumor as good as I could, and I would like to point out that on the sclera, on the bare sclera that you can see here, exactly this position here and this position here, these two positions.
We cannot see. Can you? Oh, yes, now we see.
Yeah, you see that? Mm-hmm. Here, this position here and this position here, these are the vortex veins.
Those are the what?
That are cut flush.
Vortex veins, okay.
Yeah, and this is the point that I made in the beginning. They are truncated at the outside of the eye, so that I don't have any egress from this vortex veins. So I infuse Decalin, making sure not to cause too many bubbles, because it would obviously go under the retina because of the large retinectomy. as you see, the central artery is pulsating. I hope you see that.
Wir lasern gleich.
We see it well. The artery is pulsating.
Ein bisschen runter. We lower the pressure a little bit to have a little bit better perfusion. That's fine. And after that, I will do a laser treatment on the coloboma, inside the coloboma and on the edges, obviously, and so then a direct change of heavy liquid to silicone oil.
And you will ablate the bare sclera throughout the bed of the resection. Is that correct?
Yes, that's right. That's right.
Nicholas, can you tell us a little bit more about the bleeding? So when you get bleeding during these cases, as you were getting next to the disc, is it just a question of maintaining the raised pressure? Diathermy, I guess, doesn't work very well on the choroid. Is that right?
It doesn't work very well, but I think the best way to control bleeding is to lower the fluid circulation in the eyes. So, I remove the cutter and go in with a needle, and by having higher pressure, and now I'll do the laser treatment. You can control the bleeding. I think it's better to do laser treatment than diathermy on the choroid. You can see that in a moment. I have here illuminated Alcon laser probe, which is quite useful because I can use my indenter to go to the back far periphery. So you can see that here. Kann ich den Laser-Dings haben hier, bitte? Laserpedal? Okay, go active. We go down 150 milliwatts. That's okay. I don't want to have too heavy laser on the edges of the choroid, because you can see shrinkage of the choroid, and then you will get a choroidal detachment at the edge of the coloboma. This can cause silicone oil to go under the retina, under the choroid, sorry. And you can avoid that by doing a little bit less intensity laser. But again, if there is bleeding, obviously you need to do some more intensive laser treatment.
Nicholas, you have so much experience, I hesitate to ask you, but I find that depressing with a large break with the PFO can encourage the PFO to go subretinal. And I prefer not to use a depressor, but you don't find this problem.
You are absolutely right. It is dangerous, but as you saw that, if you make a rapid movements, then you will introduce small bubbles. But if you do that slowly like that, nothing will happen. I don't think it's a problem if you avoid changes in intraocular pressure. So if the depression is slowly introduced, then you will not have a problem.
Have you lowered the intraocular pressure at this point? What is it? Is the pressure now normal? Is it sort of 30, 40?
The pressure in the eye is at the moment 50.
50.
50. So I go slowly down. When I become more confident during this procedure that there is no bleeding, because bleeding can occur any moment now. So it's a little bit of it's a tricky situation at the moment, especially if I do the laser treatment here, where I have the impression by doing laser there is a dilatation of the choroidal vessels around the laser. So I have seen massive bleeding during this procedure if you do that too quickly. And I lower the intraocular pressure slowly, so I become now a little bit more confident. So I will say tell the nurse, go to 45. Now the intraocular pressure is 45 at present, at the moment.
Oh, it's going very well. You have, it looks to us as though you have full control of the bleeding and a very nice margin. We'll come back, Nicholas. Let's rejoin Rahmen in Paris. Rahmen, tell us where you are in your case. We are with you, Rahmen. Yes, very well. Yes. So I forgive me. I will re-say that. That was a very good tip. He did fluid exchange initially to remove the subretinal fluid that was thick while the eye was filled with fluid and was able to see very well. And then he went to air, and now it was just saline, and he was more easily able to remove the subretinal fluid. So a very nice trick.
Wie spät haben wir es denn? 5 vor 10. Ja. Gehen wir jetzt auf Dauer, ja?
Machen wir mit der 10 weiter.
Very good. We will come back, and Peter, if we can go to Sulzbach, we saw you lasering the 360.
Yes, you come in time because we have finished the laser. We have 360, and we have a very stable situation, no subretinal fluid anymore, but this is due to 2 small drainage retinotomies. One is here, and one is here, far in the periphery, directly beneath the ora serrata, and now we'll
but
do
for drainage?
Sorry?
Did you do the retinotomies to drain the supraretinal fluid?
Yes. I think
okay.
the fluid came from this laser area somewhere. It was already covered with PFO. So here with these laser burns, but I can't prove it, so I didn't find a real break. And we will use Denzirone, so heavy silicone oil, and therefore I've done the retinotomies in the inferior part. Here you see I've spared the ciliary nerve. I tried to.
Very nice, yeah.
And basically we'll do a PFCL air exchange, so vision will be compromised in 1 minute. So you came back right in time.
Yeah, just one question.
We always come back right on time.
We couldn't see exactly how you managed to detach the vitreous over the vitreous base. You said that it was attached quite posteriorly, that this was the cause of the redetachment. And we saw just few pictures. You were busy with the cutter, but did you only use the cutter, the aspiration of the cutter, or did you do any other manipulation by manual surgery, peeling, whatever?
Yeah, good question. So if you reach the vitreous base, you cannot peel it off. But I use 2 functions, both with the cutter, for trying to push the...
Peter, forgive me. We have a satellite cutoff. We will come back. Hold your answer for 1 moment. Let's go to Marco Mura. Marco, we are about to lose you in 1 minute or so. So tell us your plan.
Ah, that's not fair. Okay, I'm gonna go.
If you
under
like,
air
we
now.
can
Let's
stay
see
for
what
another
happens.
hour or two, if you like.
Yes, I wish. Give me the extrusion. So I'm trying to go to air now. Give me extrusion. Extrusion. Oh, dammi il cutter. Give me the cutter. Vitrectomia. Mi metti l'aria per cortesia. Ecco. So I'm going to do air now. Let's see if I can have a flattening of this thing.
Öl vorbereiten.
Dammi il Charles, veloce.
Upsi.
The cornea is terrible, of course. Give me the Charles. Dai, dammi passivo, dai. Ok, non è protetto, vero? So, let's see what happens. I'm curious.
Me too.
The suspense is terrific.
Yeah, also for me. I don't know what's going to happen. Let's see.
So far, so good.
Stabi.
Yeah, you know you're in trouble if you see subretinal air. That's the sign that you have unrelieved traction in this maneuver, is if the air goes subretinally, then you have to do more.
So, Marco, your plan is that if it stays attached under air, you're going to laser the brakes and put oil in, or and without a retinotomy. Is that right?
Yes. You are totally correct. Let's see what's going on here. I think if I drain from this hole, it's not going to be upset, right?
Yes, other problems in the eye, I guess.
I think it's the least of the problem.
Yes.
So
The view is typically bad in an aphakic eye with air, and it always makes a difficult situation.
Spegni il candeliere, switch the
I didn't
chandelier
know
off,
you
let's
had
see.
aphakic eyes over here. Every vitrectomy I see is done with phaco, so...
Sometimes long historical cases, Don. Never fresh ones. But so when you have that situation, what do you do to improve the view? Do you, with this poor view with an aphakic eye whose decimates membrane folds?
You can try to coat the back of the cornea with Helon. That sometimes works with viscoelastic.
It seems that is attached. Actually, there is no air under. The retina is attached. Can you see?
Yeah, we see it.
Is,
We see it.
Yeah.
We see.
If you want, I can send you a picture at the end.
Machen auf
So you can send me your
2,0
mobile,
Maximum.
okay? With the oil inside.
The infratemporal area.
Look, this is the buckle.
Yeah.
Oh yes.
This is the buckle. This is the retina attached. This is the large break I show you. This is the edge inferior, the inferior break. There is no air under. This is a large break. What I'm going to do now, I'm going to put a piece of amniotic membrane here on the top of this large break, macular at least, silicone oil, and do the laser.
Well, you battle.
Sorry, I cannot show you the
You
end.
battled this retina into position. You removed a foreign piece of metal. You
Wenn
did
wir zwei
not
PFCL
get
gebraucht haben,
talked
sollten
into
wir nur
doing a
zur Sicherheit
retinotomy,
ein
so
zweites
you really did a
Stensiron
lot of
vorhalten und
positives
nicht
here.
aufmachen.
Yeah, you can see the buckle nicely now, actually, can't you? Yeah.
That fibrosis is right where the
And this
foreign
is the
body
retina.
was, just adjacent to it.
Yeah.
So
Yeah. There is no subretinal air, so there is no traction left.
Kleinen Tick
I'm
heller den
kind of
Fundus,
satisfied,
bitte.
to be honest.
Yeah, no, it looks great, Marco. You've done a great job.
I'm going to put 5,000 silicone oil and a plug to close the macular hole.
oh yeah, oil for sure here. Yes,
Yeah.
grazie. You're
Stano said
you're
to me
getting the
that next
first
time he's
applause
gonna
of the
give me a
meeting.
more difficult- thank you very much. I have to thank Stano Rizzo to have me here to join him in this operation room. It was everything perfect. Thank you, Stano.
Next time will be more difficult.
Very good. Well, we will say goodbye. We will say goodbye, and thank you, Marco, for doing such a challenging case for all of us. Thank you. Let's go back to Rahmen. Rahmen, we have a moment for a brief interview. Your case turned out to be a double header. You had both peripheral detachment and also in a high myope. What if you had left that peripheral detachment alone? What if you had said, you know, it was not progressive, the macula was not detached? What if you had left it alone?
Ich glaube, das wird reichen.
I mean, it could be the case. So the reason is that when I was looking really to the fundus, it seems that it has beyond the laser. If it was really inside the laser, that could have been an option. At the same time, honestly, we are here, we are already in the eye, just making an exchange, some laser and putting gas. I just put some SF6, but even I think it may not be useful, just air may be enough. So that could be also an option. But I agree, if it was a small retinal attachment, well controlled by the laser, I may just let it where it was, because once the vitrectomy done, the traction is decreasing. So if nothing happened before, there is no reason happening after that. So that are two options, and both of them could be good options.
I noticed when you treated the detachment Rahmen, you did laser around the break, as we would do, of course, but you also supplemented the laser around the area of detachment. And I was quite interested, because often in these cases you find that the primary break can reopen, but you rely on the area of demarcation. Is that what you were thinking about, doing both areas?
I prefer also to do something more definitive. I fully agree with you. Of course, there's always exceptions to the rule, but that would be my rule. I agree with you, Dan.
Sure, long-standing anesthesia risk. Gracia, do you have a comment or?
No, I agree. But once you are in the eye, I would try to solve the problem forever, indefinitely.
Yeah, the panel is in complete agreement with you. We would have all tackled the peripheral detachment here as well. No reason to leave a problem that can be addressed so directly and, you know, have another surgery needed in this patient. Any other comments or thoughts, David?
Yeah. No, just...
I do have a question.
Yes, I want to thank you, Dan, Gracia, David.
Thank you.
And
one last question.
Well, we have one last question for you from Gracia. She has a question.
Yes, very good. Good morning, Frankfurt. Nice to hear you. So I will introduce the case that we prepared for today. So can I have the slides, please? First slide, yeah. So it's a rather complicated proliferative diabetic retinopathy with a cataract. We just finished phacoemulsification, as you can see. We put a Clarion lens in the back. It's a 46-year-old patient from Africa origin, and diabetic case with multiple organ failures, actually, as you can see on the slides. So no present for the anesthetist, but he's doing a good job. So he had ophthalmic history of pan-photocoagulation in both eyes, which was done in Burundi a few years ago. Also anti-VEGF injections, several in both eyes. And we performed a phaco-vitrectomy 2 months ago in the other eye. Next slide, please. Here we see the other eye that's been operated 2 months ago. He had persistent hemorrhage that cleared spontaneously, but he recovered good visual acuity. Next slide, we see this is the picture of the pre-op of the right eye we are going to operate right now. Next slide. And this is the ultrasound picture also.
Inject the dye, then use perfluorocarbon liquids to displace that anteriorly, and it shows up the break really nicely. And it's peripheral retina, usually.
Look at the look on Peter's face. It tells you everything you need to know. Peter is skeptical. Do you do this technique or?
Yeah, I'm not skeptical. Very rarely I use it, and it's not that toxic because it's enough to dilute it 1 to 5. It's just enough to see some Schlieren, for these blue Schlieren. So it's technically possible, but mostly it's not helpful. And in a pseudophakic situation like here, with multiple laser burn scars, I expect several breaks, and you must not treat one single break, but you need this 360 degrees. That's what I personally think.
Oh.
Can you allow me one word?
Very interesting.
Can you allow me one word, because you have missed the denzerone filling. We used a new technique with a DORC adapter, which is proposed to be used for silicone oil aspiration, but it can be also used for infusion, and with a very large volume, and the tube doesn't go inside the trocar, but it's only put over the trocar, and we have counted the time was 2 minutes and 27 seconds for installation of denzerone. So this is a new technique, but yeah, we didn't wait. We have 2 other cases.
Well, great. Well, great, Peter. Thank you for sharing surgery. We understand you will be back shortly with another case, so we'll see you soon. Let's join Leuven. We have Dr. Stallmans with us. Peter, we're back with you. We see a capsulotomy has been done.
Yes, indeed. So I used the Callisto overlay system to Rexis. So I'm working with the Artivo 800 microscope in 3D. I'm looking at the big screen now. And I'm using, for the phaco now, the EVA Nexus system. Now, a novelty in the Nexus system is the so-called smart IOP, which means that the irrigation is now driven by the device. It's not, as it was before, by pumping air in the bottle. It's actively driven by a pump. And the irrigation and the aspiration talk to each other.
In diabetes, indeed, it's a very good solution. I hope I can use my cutter in different ways once we reach the membranes that are pulling the retina, that we can make a very good use of the small port and the ergonomy of the tip to shave really the membranes from the traction points and from the blood vessels.
Very good. We'll come back. Let's go to. Let's join Peter again. Dr. Szurman, we are back with you. Can you describe and can we have the diapositive of his case, please?
Yes, so we started with the second case. It's a persistent macular hole. It's a 79-year-old patient who underwent primary macular hole surgery also in a secondary center. And this failed, obviously. He has now a persistent macular hole of 720 microns, some drusen as well. And in these persistent macular holes, normally there is nothing left to peel. So we need another strategy to have centripetal forces to bring the macular edges together, the whole edges, and to give a guide rail for glial proliferation to close the break. In very large persistent macular holes, there are several possibilities. One, for example, in atrophic situations is the macular detachment, but here is not an atrophic closure, but just a large persistent macular hole with detached edges. So here we need an amniotic membrane, an epiretinal amniotic membrane, put on the break to serve as a guide rail.
So you'll do an epiretinal amniotic membrane patch. And what type of amniotic membrane will you be using? Is this fresh or cryopreserved or?
Yeah, good question. We all know the technique of Stano with the subretinal, submacular amniotic membrane. There he uses naive. And for the epiretinal patch, it really is like a patch. We use lyophilized amniotic membrane. The advantage is that it is better to handle. It has less immunogenic material because it's lyophilized, so I hope that there is no immune reaction. And we need just the guide rail. So it's similar to an inverted flap, for example. Yeah? The rationale behind is the same.
Lyophilized.
Yeah, so I was going to, just because, Peter, I know you're an exponent of the subretinal bleb technique, and you mentioned why you're not doing that. It's because you've got elevated edges.
Exactly, yeah. I use this...
If the edges had been flat, you would have gone for a subretinal bleb technique.
Exactly. You must have centrifugal force to bring the edges together. And if it's atrophic and adherent, it doesn't make sense just to do an air exchange, and also glial proliferation will not help. You must release the adherent edges. But if you have an open hole with detached edges, then it's similar to a primary macular hole, with the difference that there is nothing left to peel, and you need a guide rail for the proliferation. So I have no experience with the subretinal naive amniotic membrane. Even if I think that it's fascinating, I still understood the rationale behind. Obviously it works. There are more than 50 publications on that from the Rizzo group. But we have also done 2 studies on this epimacular patch, and we have in this persistent macular hole 85% closure rate. So it's not 100%.
Very good. Peter, we've just learned we can return like Lazarus to Dr. Marco Mura. So Marco, by telekinesis, we can talk to Dr. Mura in Rome. So Marco, can you show us a view of your eye posteriorly? So there you are. You have lasered the peripheral breaks. Let's orient here.
So Marco, just so you know, we can't hear you at the moment.
But we certainly see very well.
Have you put on the amniotic membrane graft? If you have, can you show us where it is?
I think.
Oh, we can hear you.
Now we hear you, yes.
Wie ist die Überstrahlung?
Marco, do you put the amniotic membrane on under air? So you've got an air-filled eye. You put the amniotic membrane on. Okay.
He is there for moral support. I'm sure he's offering you moral support.
He's seeking your forgiveness for giving him such a difficult case, Marco. So.
We could not hear that, but we can imagine it, I'm sure. You know, the only thing you didn't have in your case was an ILM flap. You had foreign body removal, you had peeling, you had, you know, retina holds, proliferative vitreoretinopathy in PDR. You had everything, including amniotic membrane. So next time you do live surgery, we want you to go further and pick a really challenging case, okay? But seriously, but a serious comment, the amniotic membrane placement, do you follow the techniques that we saw with Stano? Do you have any tricks? We've seen people using, you know, PFCL to try to press it down. We've seen a variety of things. What is your thought about the best way to position it on the macula? You said you did it all.
Unglaublich, da ist ja noch alles drauf.
Marco, do you put it underneath the retina, subretinally, or do you put it epiretinally?
It's interesting. The autologous flap technique was initially subretinal, and the majority have now moved to epiretinal placement. And the amniotic technique was originally subretinal, and the majority seem to have been moving to epiretinal placement. Or do you do it subretinally?
Well, I think Stano always does it subretinally. I know Mark is speaking to him at the moment. I think that's right, isn't it? Okay, Mark. I guess the big advantage of subretinal is it holds in place with just a gas or air tamponade, whereas if you put it epiretinally, they can sometimes displace if you use air or gas tamponade.
It would be interesting to see a visual acuity comparison between those two types of placement, if one produces better vision than the other. Well, thank you again, Marco. You shared, obviously, you got the only applause for this session. I'm trying with my jokes, but I'm not getting any applause. So but thank you again. Wonderful to see both of you Italians. Take care. We have an announcement. If Dr. Ziegfeld, Priglinger, if you could provide your slides to the speaker ready room. They don't have your talk. If you could please check with them. So let's rejoin. Who should we rejoin here? Let's rejoin Leuven. Peter, we're back with you.
Okay. So meanwhile, I've removed the cortex from the lens. I did the capsule polish, and now I'm about to implant the IOL. The implant lenses that I use are hydrophilic plate lenses. This is a Zeiss Asfina, and there's a few good reasons why I use these plate lenses. First reason is that you can insert them through a 2mm incision, and the shape of the lens allows you, during your vitrectomy, to look through the plate, so you have a good retinal viewing afterwards. So this is a toric lens. You see there's a line on the lens. The Callisto system is now projecting two lines on the eye. Maybe some people are not familiar with this alignment system, so we have a pre-op photo of the eye when the patient was sitting supine. While the patient was asleep, we took with a microscope a new photo. The photos were compared, and the system aligns the horizontal axis, because when patients are asleep, sometimes the eye rotates. So this yellow line is the horizontal axis when the patient is awake. That's the 180-degree axis, and the purple lines or the blue lines are is the angle at which I should implant the IOL. This is 22 degrees. To rotate the lens, I use the same bimanual system as I used for the cortex removal. I can easily rotate the lens, and the overlay system, it's like augmented reality, really. Helps me to align the lens properly at the correct angle. A little more. I'm almost there. Now I am. Okay, so the lens is exactly aligned as required, and now I will remove the visco gel from the anterior chamber. The lens is rotating.
And Peter, you obviously haven't found a problem, even in gas-filled eyes, with these lenses rotating post-operatively. They're pretty stable once you put them in position.
Exactly, and that works better in my experience with plate lenses or four-haptic lenses than with J-loops. J-loop lenses, my experience anyway, tend to rotate a little more post-op than when you're using a plate lens.
Do you intend to do a primary capsulotomy? Because obviously hydrophilic lenses will have more capsule fibrosis, or is that a consideration?
Well, I don't do it as a routine, because if you do and you have Murphy's Law and you do a gas or an oil tamponade through the capsulotomy, sometimes the tamponade can get into the anterior chamber, so I want to avoid that. On the other hand, as you may have seen, I do an extensive...
We will come back, Peter. We need to go to Sulzbach now. Dr. Szurman, we're with you. We're watching you deal with amniotic membrane here.
Yes, first of all, it's really interesting and also irritating. I've rarely seen a persistent macular hole with so much vitreous, and I've rarely seen a macular hole with half of the ILM still in place. All the inferior and the nasal hemisphere or part of the macula were full of ILM. So I have peeled it, and of course you can ask the question, is it really necessary to do an amniotic membrane? And I must frankly speak, I'm not sure, because if there is so much ILM, maybe this is enough. But we've started with the ILM. It's a 6 millimeter punched lyophilized amniotic membrane, and I take it with, so I use 23 gauge trocars, the Evita trocars from Dork, where you can remove the cap, and I introduce it with a 27 gauge forceps, so I can easily introduce it, and yeah, there it is.
Peter, you very carefully folded it there. Were you thinking about, folding it with chorion side in, or does it not matter?
It doesn't matter because it folds in a special Kann ich den haben? Yeah, always with the epithelial side on top, but it doesn't really matter on lyophilized because it nearly consists of 100% basement membrane and nothing else. So there is no real chorion on it, compared to naive amniotic membrane.
That's a nice way of putting the valve back on with the trocar, actually, as a passing comment.
I've removed the caps, as you have seen, and now I've reintroduced the caps to have a stable situation. Okay, there it is. It rolls, similar like DMEC. Nochmal sauber machen und nochmal Methoxyl drauf. And we will fix it with PFCL. And under PFCL, we unroll it. and we do it a bit peripheral from the break, and we will then pull it under the PFCL over the macular hole.
You've also described a nice technique where you do a partial fluid air exchange and put the amniotic membrane at the interface, which unfolds it. Is that not very reliable, or have you stopped doing that?
Yeah, David, you are well informed as always. So I've not decided which one is the best technique. I've started with this technique underwater. I have a bit more experience with that. With unfolding under air, it sometimes works very elegantly, but not always. I'm not sure, frankly spoken, which one is better.
We'll find out in a second.
Yeah,
this technique is faster. You see it.
Technique.
Nice.
Yeah, it already unrolls. Yeah, so this doesn't seem very complicating. It's already half unfolded. And David, you see it's faster, this technique. Yeah? The other is elegant if you have only a small water remnant and then it spreads on the surface of this water remnant. But nevertheless, you must also unroll it.
I'm impressed by how large this piece is on the macula. You know, it's huge.
Yes.
You don't find any negatives of having such a large piece of amnion over the entire macula?
No, we have 38 cases in our study currently, and no, it sticks to it. And you really see some glial proliferation and adherence, so a centripetal force of the breaks. And David, I think, has said that, and he is right, it's very difficult to do it with gas. We have only 4 cases with gas in our series, and 2 or 4 were lost with the withdrawing gas bubbles, so we need Denziron oil.
And you were saying this particular amnion always rolls so that the chorion side is down. It's outside, correct? The epithelium is inside, is that?
Yes, and I think I have no chance to do it even differently, even if I want. It's really comparable to the DMEC roll. It's very difficult to use it inversely.
And how about cryopreserved amnion? Have you experience with that? Does it work as well?
No, I didn't try. Lyophilized is the maximum degeneration of all immunogenic epitopes. Naive, of course, it has these growth factors. This is nice, but it's heterologous tissue. So it has all disadvantages of immunogenicity. The lyophilized is really highly denaturated, and all cells are gone 100%. All choroidal tissue is gone. So there is only the naked amniotic membrane. Of course, this consists of collagen, and collagen has also immunogenic epitopes. And I think that we talk too little about the immunogenicity. In corneal transplantation, we always talk about that, and here in the retina, we stuff it under or over the macula. And I think this is a milestone, but we should add to the discussion the thinking about the immunogenicity. And the problem is that we rarely explant the subretinal amniotic membranes to do histology on that. But we have histology for several explanted lyophilized amniotic membranes, where we have explanted it after a silicone oil release, and tomorrow I will have a talk and I will also show you the histology.
I think one of the nice things about an epiretinal technique is you don't risk damaging the RPE, especially in cases like this where there's pre-existing AMD. You know, with the work that Stano's done on possible regenerative abilities of amniotic membrane with AMD, it might have an additional role in aiding.
Could be.
Yes, so these are my objections as well. With the subretinal, you stuff it and open the macular hole. You have no idea what happens in the subretinal space. Basement membrane or an amniotic membrane is known to be water resistant, so there is compromised fluid transfer through the membrane. Lupenwechsel. So you don't know if this is an obstacle for the.
Peter, if you were to, does that amniotic membrane dissolve after a number of months? I mean, do we know if the retinal sensitivity is compromised by being covered with such a large piece of material, or does the amniotic membrane gradually melt away?
Yeah, I didn't know, because on the cornea it melts, but in the retina we have results after more than 2 years, even 2.5 years, and there is no melting. But it's wrinkling in some cases, yeah? So it shrinks a bit. Nochmal Methozel und Lupe sauber machen.
Have you done microperimetry studies?
No.
During the months to see if something changes concerning the retinal sensibility?
Good question.
Hold that question because we need to go to Leuven. Peter, we're back with you.
Nee, dat is goed. Dan kan ik het zo laten dan. Ja, oké.
Peter?
Ja. Ga maar terug.
Stallman, sorry, both two Peters right now.
Yes, okay. Okay, yeah. Okay, so I've installed my cannulas. This is the Dork Avita system. When I have to inject fluids in the eye, like perfluorocarbon, for example, I use the 23-gauge system. I think Peter Szurman nicely demonstrated how you can remove the valve and put it back on. But there's another nice feature in this Avita system, that's the push fit. So you don't have to take the cap off to mount the infusion cannula. And so during surgery, you can, for example, easily switch to another cannula whenever you need this. You don't need to take the cap off. But as is shown before, if it's necessary, you can take it off and put it back on. Okay, now, what I wanted to show you is something completely new. Sorry, I didn't switch it on completely.
Wir nehmen eine neue Braunlüle und machen die einen Tick länger.
I think this is a nice safety feature, keeping the valves on. Yeah. But you don't put your infusion at right angles. I think a lot of surgeons would do that. You don't worry about it going suprachoroidally.
If you don't exaggerate, the infusion cannula is long enough to stick well in the eye. I always make my incision a little bit in an angle so it closes easily, more easily at the end of the surgery. Now, what I wanted to show you, can you give me the overview, is the new ReSight lenses. So I'm sure you're familiar with this green lens. This is the 128 diopter reusable ReSight lens. It's made in glass, it's reusable. But now there's a new version will be released probably next year, and that's a disposable version. I will show it for you. It fits in the same holder. It's made in a polymer, in PMMA, and it doesn't have this yellow ring around it. So the optic size is the same as the old one, but it's smaller in overall diameter, so it's easier to use in smaller eyes. Also, the optics have been reworked to give you a better image. And of course, a major advantage is that you always have a new lens. If you reprocess a lens, it gets scratched, there are stains in it, smudges, and in the end it will start hindering your vision. Also, a lens in glass is colder, will easily condensate, while the disposable lenses are in a polymer, hence they condensate a lot less. Now I think I can show you the difference even through the transmission when I switch lenses. So now I will show you the fundus view using the regular lens, the old lens, and you see condensation is occurring. I'm not sure if you can see in transmission, but on my screen I see fogging. I will now switch to the new lens, and you will, for me it looks immediately sharper, and there's no condensation showing, although the lens is at the same distance of the lens and gives me the same magnification. So this is the first novelty I wanted to show you. This is called the wide angle lens, and so it's a disposable replacement for the 128 yellow lens that users of the Lumera or the Ativa systems are aware of.
We have a terrific view. We have a wonderful view through the lens. We will come back to you. Let's rejoin Karl Kleiss in Antwerp. Karl, we're with you.
Hello again. Yeah, we proceeded, of course, nicely. We could remove the blood and the vitreous for the periphery and the mid-periphery. We see some retinal detachments nasally and temporally, and some vitreous adhesions, some posterior hyaloids. We did all the work now with a 27-gauge cutter, and it is very nice. We can come very close, and we can use the cutter actually as a kind of scissors in this kind of membranes that are very close. We just put the tip of the flat part of the cutter on the membrane, and we can actually shorten the membrane without engaging the retina in this way. 20,000 cuts helps, of course, to minimize traction to the retina. We can come so close, and now we see exactly the adhesions, and we can go for the dissection of the adhesions. We can slip underneath the vitreous membrane and try to, even by manually, detach the vitreous more centrally to release it completely. Yeah.
We have a great view of a nice plane of separation and bimanual technique with cutter and forceps here. Very nice.
What chandelier is it, Karl? Because we have got a great illumination. It's a very good view.
This is the Alcon chandelier.
And where have you positioned it? Where is it positioned? Is it infranasal?
I prefer nasal. Yeah, exactly. That's my preference location.
Oh, okay.
Only exceptionally, I would choose another location.
Great, and let's go to Sulzbach to Peter Szurman. So, Peter, you're finishing already.
Yeah, we are preparing for Denzerone exchange, and you might ask what I'm doing there for 5 minutes with Staubsauger, with fluid air exchange, but it's necessary to fix the amniotic membrane for about 5 minutes, Lupe, under PFCL, so it becomes sticky. Otherwise, during silicone oil exchange, it will dislocate. So if you
so 5 minutes of pressure under PFCL is needed to secure its position, is it?
Yeah, and even then it can happen. So this is the biggest technical problem, that you must instill the silicone oil not from the side, but directly above the epiretinal membrane. If it comes from the side, it can push aside there. You see? Have you seen that it has moved a little bit?
Yeah.
And therefore, I really dry very meticulously.
And you are going to use Denzerone, not normal silicone oil?
Yes, we have shown in both studies on persistent macular holes that silicone oil 5000 has the same success rate like Denzerone, but the eyes regularly, really regularly and significantly end up with a lower visual acuity. I'm not sure why, but nearly all eyes have.
Please repeat that. Which had lower visual acuity, the silicone oil or the Denzerone?
5000. The 5000 has a lower vision, and Denzerone has a similar vision like gas. So I use only gas or silicone oil in macular holes, in all macular holes.
It's interesting, because there's very little reports. There's very few reports of silicone-related visual loss with Denzerone compared to normal light oil.
Yeah. The first study was on various kinds of persistent macular hole surgery. It was a cohort of 78 patients, so a rather large cohort, and the results were significant.
Do you think there is a difference between the 1,000 and the 5,000?
I have no experience with the 1,000, except that if I get a referred patient, I'm always angry about the emulsification. But I know that there are fans of silicone oil 1,000, but except that it's faster to instill and exchange, I don't see any rationale for that.
And Peter, presumably using Denzerone Extra, are you? You're using the new version of Denzerone?
I'm not sure if I know what. Maybe you can give some more details. I don't know this term.
Actually, I'm going to. There's some talks on that, so we'll come back to it later. But it's the Siluron Extra equivalent.
If you tell us now, we can go out and miss your talks. That would be totally. So this, you're being incredibly delicate because that flap is moving quite a bit with every draw of fluid.
Yeah, exactly. That's a critical part, especially when I instill now the silicone oil. So I really use a long cannula and try, steht auf Öl? And I will take care that it goes directly above it.
The oil cannula in, okay.
Yeah, but after that, once it is, it sticks. So after 2 days, then it's really sticky, and you can even see in OCT that it's glued to the retinal surface. And it also withstands, after silicone oil release, it's not easy to remove it.
Do you do a direct exchange PFO Denzerone, or do you always go through air first?
This might be a solution, and I'm not really experienced in it. I've never liked it. It takes a long time. I'm afraid that I don't see well. I'm afraid of remnants of PFCL.
For autologous retinal grafts, yes, the flex loop works really well, doesn't it? Yeah.
How about for this?
I haven't got any experience of this technique yet. But it would make sense. Yeah.
Yeah, it's a perfect demonstration of the dislocation. It's not the case so this is more than the average.
This is the head tilting, to my opinion, helps in this because you more likely to keep it air covered. I don't know whether Gracia or Don have got any comments on that.
Mm-hmm. Yeah, the impression is that there is still some fluid underneath, and unless you aspirate it, it's going to be sleepy on top of.
Yes, there was still some fluid. Maybe I should have waited 5 more times.
Yeah, what I usually do is to do an exchange, with direct exchange PFO air and try to dry as much as possible to avoid to reach I try to aspirate all the water before removing the last drop of PFO. But of course, it's different if you inject Densiron at the end.
Yes.
Yes, you wonder if you could manipulate it under Densiron, as Marco just did with the trauma case.
Amniotic membrane.
Although that was normal oil, light oil.
We'll come right back. Let's go to Leuven. Peter Stallman, we're with you. Peter.
Yes. I promised you I would show you some new things, so let me show again something new. Can you please show the microscope overview? This is the 60 diopter lens that we use for macular surgery on the RE side. It's again a reusable lens. This has been reprocessed, I think, a few dozen times. Now there's an alternative that we've designed with size, which is this one. So you see that the size of the lens is larger than the previous one, but it doesn't matter because it floats so high over the eye that it doesn't hinder your instruments. But since the diameter of the lens is larger, you have a better overview. You see better your instruments when you come in the eye. Now, I will show you also the difference in quality. So this is the view that you have with the reusable lens. I switched on the OCT. You can see the retina is detached. This is the best OCT that I can get out of it. Now I'm switching to the new lens, to the disposable macular lens. I have to refocus somewhat. And first of all, you see what a better overview you have, but also the sharpness of the OCT is so much better. So this is the second novelty. This lens should give you the same quality of view as you have with the contact lens on the macula. So what I will do next is inject perfluorocarbon liquid. And you should now look on the overlay on the left at the infusion. The active infusion system of the Nexus shows you the amount of infusion in the eye, which is now varying 0, 1, 2. When I will start injecting perfluorocarbon, I will push out the liquid from the eye through my infusion line, and you will see that a negative flow occurs, -6, -2. And that gives you a control that the infusion cannula is not blocked by residual vitreous. So that allows you to safely fill the eye without overpressuring it. I will have a look again at
Very good.
The OCT.
We will come back. Peter, let's go to Antwerp and see where Carl is. Carl, we're back with you. A lot of progress here.
Hello, yes. We managed to detach most of the posterior pole. Here you see this completely circumcised membrane here. So we put the tip on the membrane and we aspirate and cut very fast. In this way we can really shave a big part of it without engaging the retina, as you see. Of course there is blood vessels, but we see there is no retinal break. The membrane is completely gone without instruments, just by the cutter.
Yeah, I have to leave. We'll come right back, but we have to go to Sulzbach.
And this is, you can see how we nicely detach the vitreous, Carl, just by
Peter Szurman,
like spatula-like.
Okay, Peter Szurman, we're back with you. You wanted to show us.
Yeah.
This is a different patient, yes?
So we've finished the case. I would like to share the final view. I'm happy that you have seen the critical part of exchange with dislocation. Yeah. So dry it up as much as possible. Wait maybe 10 instead of 5 minutes. But once the silicone oil is in, nothing moves anymore. It was only in the beginning, but when I had the first half milliliter in it, there was not at all any movement. And after a few weeks, it's really sticky that you cannot even peel it off after silicone oil exchange. Or you can,
so
but...
Peter, one thing that you did, but I don't think we mentioned specifically, is you used something like an angiocath or a long plastic cannula to be able to introduce the oil close to and directly on top of the amniotic membrane, correct? You used some kind of an angiocath type system. So, yeah, very good to see it.
Yeah, maybe I'm not calm enough to wait for silicone oil installation with the classical 23 gauge Weber cannula or via the infusion line.
Because if he just introduces it directly through a cannula or something from the pars, it's going to move the flap, the amniotic membrane, displace it. So
have you ever tried moving the amniotic membrane once you've got the oil in? Can you maneuver it at all, or is it?
Yes, I've maneuvered it once when there was about 0.5 milliliter in it. And also in this case, where I had this dislocation, I already had the first drop of silicone oil on the membrane. It was only one drop, but it's possible to maneuver it. I think it would be possible to maneuver it now as well. But during installation, there is no fluid force to push it aside anymore. So I became relaxed when I started to instill the silicone oil.
Very good, Peter. We will come back at the end if we have a moment. Let's go back to Antwerp. Carl, we're back with you. We apologize we had to cut away, but...
just can show you the way we detach the vitreous from the disc, and now we are dissecting in the right plane, and then dissection goes smoother. You see it's very strongly attached, but again the 27 gauge cutter allows us to slip underneath, and the position of the port allows to cut away from the retina and to actually remove it for 99% in this way. We have some adhesions in the mid-periphery here, and we will proceed in the same way to just dissect it with the cutter. See almost no movement of the retina when we shaved off the membranes from the surface. The retina is mobile, it's a detached retina, as you can see. There is a break here, which is not iatrogenic, by the way, but we try to detach the retina from there as well. We can proceed in a bimanual way in those areas where adhesion is too strong. But it's a little bit circumcision of the membrane. It's a different technique. It's a divide and conquer technique like the phaco. It's like we used to do en bloc technique more. With conventional dissection, we now proceed more in a divide and conquer, and just the epicenters will be trimmed away by the cutter. Traction will be completely removed around it before we do that safely.
So your use of scissors is very infrequent. So even in a case like this, you're not tempted to get some scissors and use bimanual scissor dissection?
Exactly, yeah, that's a completely different approach now, thanks to improvement and miniaturization of the instruments.
Very good, Peter. We will come back. So Dr. Szurman, let's return to Sulzbach. So very nice. You battled the flap into perfect position, and we all learned how delicate and careful the technique must be. Any other comments you would like to make? You showed many things. You showed the direct on top of the flap amnion installation of silicone oil, which I think is going to help a lot of us, because I have tried to put it in from the periphery and it knocks the flap out. I haven't tried such a large flap, but I have to say I'm intrigued to see, because it looked like in some ways easier to control than a small piece of amnion. But your comments, please.
Yeah, so the silicone oil installation is a critical part. I think we've learned really with this dislocation that the fluid is relevant, that the PFCL helps a bit, that it might be a solution to do a direct PFCL silicone oil exchange, as Gracia has proposed. I just don't do it because I'm not patient enough. And sometimes it happens to me, at least, that there are PFCL bubbles, remnants, that never happen with air silicone oil exchange. And I normally don't use this angiocatheter anymore. This was my standard technique the last 10 years. Today I use this novel high diameter cannula from Dork for Densirone instillation, which is the fastest. But for this technique, I need it because I have this long tube and I maneuver it exactly over, in the middle, over the amniotic membrane. And this is not possible if you have a trocar-based installation. So in my first case of retinal detachment, I use this newer technique, which is faster, less invasive. It doesn't need to be sutured, but for amniotic membranes, I still use it.
Well, very good. Well, Peter, we want to thank you so much for sharing 2 beautiful surgeries with us with many new tricks and pieces of information. We look forward to seeing you again very soon. Thank you again for beautiful surgery. Thank you.
Thank you.
Take care. Bye. Let's very good, and you hear the applause. Let's rejoin Leuven